Hey, welcome back, everybody, to the We Fix Pain podcast. Yes, I know it's been a minute. My name is Dr. Pappas. I'm a sports and rehab chiropractor practicing with Airrosti in Austin, Texas. Give you a little bit of information about the podcast. The We Fix Pain podcast focuses on health and wellness related topics with a specific focus on integrated neuromusculoskeletal care. We discuss injuries to muscles, tendons, ligaments, joints, fascia, bones, nerves that lead to pain and pain-related conditions. We address topics like assessment, diagnosis, treatment, rehabilitation, and management of acute and chronic related pain conditions. We thank you, our listeners, for listening and watching our podcasts, and humbly ask if you like the material, please subscribe and share. We got an awesome and amazing guest, Dr. Tom Teter. Dr. Teter is a chiropractor, manual therapist, sports medicine specialist, performance enhancement specialist, and educator that studies and teaches in the areas of neurophysiology of motor control, pain, injury, and physical performance. He is the creator of the Rehab to Fitness courses and certification that seeks to bridge the gap between pain, rehab, and fitness. He's also created a 16-week, yes, you heard that right, 16-week interactive cohort training program and certificate called Clinical Human Performance Practitioner Certificate. We are honored, we are blessed, and we are thankful that Dr. Teter made the trip back to the United States from the beautiful beaches of Valencia, Spain, to speak with us, but also to hang out with family in Kansas City, Missouri. Doc, welcome to the podcast. Thanks for joining us.
Thanks for having me. I appreciate it.
Doc, so just one of the questions I like to start with. What's your origin story? Every superhero, including yourself, has an origin story. What is it?
My story goes all the way back to high school. I had a really massive spine injury into my junior year of high school. I was maxing out for weightlifting for football and did way too much weight, more than I had any business trying to attempt. And at the bottom, when I got stuck of a squat, instead of dumping the bar, I tried to be a hero and try to come out of the hole. And I flexed and rotated and immediately felt a massive pain, fell to the ground, and voila, had a L5-S1 disc herniation that was extremely severe. I ended up having to have surgery because I essentially couldn't walk. I wasn't paralyzed, but I had no motor function, and it was just the most extreme pain I've ever felt in my life. So I had surgery. And that's kind of what started my interest in the human body. I went and from there studied, did a bachelor's degree program in exercise science. So I was always interested in performance and exercise. And then my journey into specifically chiropractic started after college. I was weightlifting and had a really intense neck and shoulder pain. And my partner at the time, my weightlifting partner, is like, hey, you should go see my chiropractor. And not having any experience with chiropractic whatsoever, I was reluctant, but he convinced me to go. And when I walked in the door, my pain was probably a 9 out of 10. And when I left, it was like a 1 out of 10. And I was just in complete amazement of like, what the hell just happened to me? And at that moment, I was kind of searching for education options to kind of further my path. And I was like, that's really interesting. I should look into this. And after kind of looking into chiropractic and seeing the differences between chiropractic and physical therapy, I chose to go the chiropractic route. And 6 months later, I enrolled in chiropractic school, and I graduated in 2005.
Yeah, you have a very personal experience, it sounds like, both from two injuries. And I know there was a book out. It's called The Gift of Injury, written by Stu McGill and Brian Carroll. And it sounds like that injury sets you on a very personal quest to be as good as you can be in the areas of sports medicine rehabilitation, because it was personal to you. And you can probably connect the dots that somebody else has probably had the same thing coming out of the hole in a squat or lifting or trying to improve their health. Something similar happened.
Yeah, and now knowing all the stuff I know, 30 some odd years later, um, I realized how things should have and could have been done differently. I'm very thankful for the ability to have surgery at the time because that's what I needed. I know when we have these discussions about discs and surgery, there's a lot of controversial opinions, but I was in that percentage of people that absolutely needed it. And it gave me the ability not only to have a unique perspective on other people's injuries, but then for me, they told me when I was having surgery that I would never play football again. I would probably never do athletics. And after my surgery, within 3 months, I was black for my senior year of high school football. So it was maybe 3 or
Awesome.
4 months. So it was just like I got to figure this out. And then what's really helped me professionally is having that injury and knowing what the most extreme case can feel like. It's easy to relate to people and be like, well, here's how I dealt with this. Here's the things that I had to interact 30 years ago when I went through it. So I'm kind of thankful for having that injury because it kind of led me down a path to be able to sit here and speak with you.
Yeah, and we appreciate you sharing your personal story. And yeah, I'm 100% on board. You start dealing with neurological and motor deficits. That's kind of the wheelhouse where I don't know if conservative care is going to work. And statistically, and according to the data, yeah, you probably were the right person for the surgical procedure to preserve your long-term neurological and motor status. A gift of injury definitely applies to kind of what you felt and what you're describing. Hey, so Tom, you're an expert and you've created modules, certificate training programs in the area of rehab to performance and pain to performance. What is this space? What does it mean to you and what should it mean to other providers when we talk about rehab to performance or pain to performance? What's the 30,000-foot view?
That's a broad question, but I think to me it's everything that we do. I think there's a misconception that the idea of rehab to performance or that concept only applies to athletics, but it really applies to everything we're doing with every patient. I think the 30,000-foot view is rehab to performance starts at the onset of injury and ends when the patient is back doing everything they were supposed to be doing or need to do at full function, well, regardless of whether that's athletics or not. The bigger thing for me is, and this is what we're starting to teach in our courses, is that this idea of rehab to performance isn't just about rehabilitation, although that's part of the process. It's really about human performance. Everything that we do encompasses human performance, and we can dig into that shortly if you like. But I think part of the challenge that I've always had is people segment their rehab into tiny little phases, which is fine, but that also silos out other providers. And in my opinion, this whole idea, rehab and fitness and training is concurrent if you have the right model. So that shouldn't be necessarily be something that we segment. They all should be happening concurrently if you have the right system and model, which we teach, and if you're doing these things in the right order. And so I think the other thing that, since we're touching on it, the other thing I always talk about is I'm not real keen on the language of rehab to performance because performance is an outcome measure, right? And there's lots of things that we as clinicians can't control on how people perform on the field and the outcome of performance. What we talk about and why we named our course this way is rehab to fitness, because fitness is a quality that we can train and or acquire for our patients. And so my job as a clinician is if you're injured and we need to go through this process of a spectrum of loading strategies to get you back to where you're performing, is I need to give you development of all the specific qualities you need to be fit enough to be able to perform and express tactics and techniques of sport. So we try not to, I understand the nomenclature of rehab to performance, but I much, much prefer the language of rehab to fitness because then it tells us what we're trying to do. We're trying to rehab you back to the fitness qualities you need in order to perform at your best.
Yeah, I think the topic of performance or the word of performance, you know, it's an interesting word. It doesn't necessarily apply to what we think it does. I think you nailed that kind of hit the nail on the head there. Whereas fitness is a broader, more encompassing category. In the performance space, there's things that we can control as chiropractors and sports medicine professionals, and things that we can't. The psyche, what's between an athlete's ears, their makeup, their nutrition, their inherent ability to believe in themselves and their abilities despite doubt, right? I mean, there's more than just muscles, tendons, ligaments, joints, movement patterns, the stuff that we're drilled on. So I think you're right in saying it's rehab to fitness, prepping your body and even prepping your mind a little bit through training of the body. Physical training is mental training, but I think the performance one is a gap. It's the shiny object, but there's a lower hanging fruit on the tree that branches in fitness to performance. So I kind of like how you describe that kind of pathway. That being said,
Yeah,
what is your starting
I think
point?
that if we,
Every good story has a starting point, it has a middle and as inclusion. What is your starting point in this space of rehab to fitness? What does that look like for an average patient, an average case, or an average situation?
Sure. So what we teach is that rehabilitation is a continuum of loading interventions. And one of the things, I know you mentioned that we might talk about this later, but what I always describe, and it might be easier to explain it in this way, is what I was trying to explain this complex topic to students, and when we decided to come up with the course, I think the problem is we have all these interventions that we do regardless of your professional designation, but no one has really talked about what they do to the body from a load perspective, and then using that as the metric for their application to the organism. And so, what we talk about is rehab is just a spectrum of loading strategies. Now, we teach that there are 6 stages. You talked about where's the beginning. There are 6 stages of rehab. These are all along a
Like, is that
spectrum.
like 6 degrees of, is this like 6 degrees of Kevin Bacon, but in the rehab world?
Essentially, yeah. So there's 6 stages.
I'm
Those are
I'm
acute.
I'm a corny guy, so occasionally I'll get the good one-liner in.
I'm totally fine with that. We have acute management, foundational kinematics, motor control, functional integration, which functional integration is where typically we would say fitness starts, but functional integration is just GPP, right? General physical
General
preparation,
preparedness. Yep.
right? We have we have progressive kinetics, which is special physical preparation. And then we have fundamental capacity, which is special physical development and motor skill acquisition, right? And then that's where people get discharged back to sport. So it's a linear line of stages of care. Now, not that these stages are done separately from one another, because typically 2 or more of these things can occur at the same time, right? But if we talk about these individually, each of these stages have their own priorities, their own goals, their own interventions, and their own exit criteria. And so for acute management, we obviously know this is where someone gets injured, right? We're trying to protect them from hurting the tissue further. We're trying to reduce pain, inflammation, and we're going to isolate on a specific joint, muscle, or nerve and use really low threshold graded exposure in a highly controlled environment. We as the clinicians are going to control everything that they do. So the goals are just to provide a safe healing environment, reduce pain, decrease tissue sensitivity, reduce swelling, and decrease inflammation. When we look at the interventions, and one of the things that I'm really proud of that we talk about in the course is if we really start to look at the things that we do from a load application, we want to find the right intervention for the right person with the lowest systems load. And so what we did is we took all of the interventions that everyone does in this space in each stage of care, and we ranked them based on a theoretical load to the system, right? So the first thing we do in acute management is what? We do patient education. Here's your diagnosis. Here's how we're going to correct it. Then we look at simple strategies for decreasing pain, things like diaphragmatic breathing. We have static or dynamic taping. We have things like cold laser, dry needling, or dry needling with electrical stimulation, depending on where you're at and what state in your certifications you have. We can use things like vibration or percussion, or any type of acoustic wave, shock wave, etc. Now, there's other ones that we're working on putting into this theoretical construct, but that's the things we do in acute management as chiropractors, physical therapists, physios, etc. And then the exit criteria for this stage of care is to reduce pain by 75% and reduce swelling by 75%. And the way we think of this is those exit criteria just means that you don't need to do this stuff anymore, right? We're moving past that because the whole goal of rehabilitation is to restore function. And the only way we can do that is through the application of load and long-term exposure to stress. So we've got to find a way to move these people down this continuum to get them to the point where we can actually put them under loading strategies or
Yeah,
high threshold loading strategies.
you're using all those tools, patient education, getting a diagnosis, possibly passive modalities, including but not limited to the application of selective manual therapy, selective manipulation to get them out of the pain hospital because they can't stay forever in this pain hospital, to move them into a separate categorization, basically.
Kind of. What I always talk about is everything we do in the clinic is solely for the purpose of getting people into positions where we can load them, because that's where long-term physiological adaptation occurs. And so I don't care what it is, but what we had to do is find a way to organize it, to teach it, right? And I think that's the challenge with a lot of our students, particularly in chiropractic school, is they hear all of these different things that we're now discussing, but they don't know where it goes, when to use it, and how it applies to the larger spectrum of rehab to performance, rehab to fitness. After we get done with acute management, then we get into foundational kinematics. We're going to work on altering the range and direction of motion in a specific joint. We're going to reset input to the system, and we're going to try to enhance connective tissue repair, increase input to the central nervous system, reset joint motion, improve tissue sliding and gliding, etc. And then some of the interventions that are very common are things like myofascial decompression, essentially cupping, compression flossing, a nerve flossing, like neurodynamics. You could even do peripheral nerve entrapments, which is a combination of nerve flossing and manual therapy. And then you could do joint mobilization, any flavor of joint manipulation, and any flavor of soft tissue manipulation. But if we look at those in a hierarchy, we would agree that using a cup to try to decompress tissue is a whole lot less systems load than really aggressive deep tissue manual therapy, right? So it allows us to pick the tool and pick something that has the lowest systems load. So those are all the things we're doing in kinematics. We're trying to restore motion. Then motor control is where we're trying to progress them into reinforcing essentially efferent output. And so we're trying to promote joint centration. We're trying to get proper link tension relationships so that they can actually use low threshold muscular contraction to stabilize a joint. And here we do things like positional isometrics, which I think isometrics, to be honest, is the lost art of clinical practice. There's
I
so
agree.
much that we can.
It's an underrated and
Isometrics
underutilized tool. Yeah, yeah, 100%.
do so much with isometrics, even on the performance side. But in clinical rehab, we can use isometrics. We can use things like developmental or positional stabilization. I like to use terms that are non-commercial, but that big fancy word just basically is DNS, like developmental positional stabilization. You could use DNS strategies to centrate joints and improve efferent output. We could do things like combined loading, concentric and eccentrics. We could do strictly eccentrics for things like tendinopathies and some more higher threshold loading strategies. And then we can kind of tie all that together with blood flow restriction, right? And so now we have this, if we look at these first three stages of care we're discussing, this is typically where people think rehab happens. But we've just described a different series of loading strategies to get someone to the point where now we can get them weight bearing or semi weight bearing and actually start to increase load in the tissues to create long term physiological adaptation. So then you ask where the beginning was. Well, it's acute management. Well, where does fitness or performance start? It starts at the beginning, because while we're doing all this fancy rehab stuff, we're also going to be working with them to load the stuff that we can still load, because we know that has benefit to the system to not only heal the tissues that are damaged, but also to keep them fit in the areas where they can still function while we're bringing everything back to normal. But in theory, fitness kind of starts at functional integration. And this is where we're going to work on magnitude of force production. We're going to reload functional movement patterns, and we're going to get them weight bearing, and we want to improve body relative strength and aerobic endurance, right? That's GPP. Some of the interventions that we will typically do in this stage are like fundamental movement patterns, working on different types of strength, whether that's maximal strength, dynamic strength, submaximal strength, or repetitious strength, just depending on what is specific to their very specific needs. And then we're going to do resistance training in the trunk and spine, upper body or lower body, and then couple all that together with some low threshold aerobic endurance work. And then from there, we move on to progressive kinetics, where we're working on rate of force development and rebuilding their athleticism. We're going to do things to improve rate of force production, stimulate fast twitch muscle fibers. We're going to shift the force velocity curve to their favor. And we're going to use interventions like explosive power, which is a one-time force production, recycling power, which is multiple bouts of low threshold force production. So recycling power could just be running, but we're also going to work on sprinting, jumping, and throwing. And if your sport dictates it, we'll also work on Olympic lifting. Now, as a side note to that, in the course, what we typically teach is sprinting, jumping, and throwing. I don't teach Olympic lifting specifically for two reasons. Number one, well, three reasons probably. Number one, I'm not great at it. So I'm not a great teacher to be able to teach someone else how to Olympic lift. I have some friends who, one of my friends was an alternate on the US Olympic weightlifting team many years ago. And it took him 15 years to develop the motor skill and the specificity of that movement pattern to do it at a high level. If we're trying to make people athletic, if you look at the idea of rate of force development, Olympic lifting is only about 2.4 to 2.7 meters per second. Where you have sprinting, jumping, and throwing, sprinting can be up to 11 meters per second. Jumping can be anywhere from 8 to like 9.5, 10 meters per second. And medicine ball throwing can be anywhere from about 7.5 to 9.5 meters per second. So if we're trying to find things to work on rate of force development that actually is going to increase velocity and stimulate fast twitch muscle fibers, those three options are way better with a lower learning curve. And they're more applicable to direct activities of sport. So we typically don't teach a lot of Olympic lifting unless the person says Olympic lifting is my sport, or I have to do it as part of my return to play protocol. And then the last stage is fundamental capacity. And this is where you're working on change of direction, agility, reaction time, motor skill acquisition, and work capacity. So, again, some of the interventions are working on agility drills, reaction drills, change of direction, sport specific skill, which this is where you start to integrate coaching back into the process. And then finally, work capacity and giving the person the ability to be conditioned enough to do their sport for a long period of time. Each of those stages, like I said, have their own exit criteria. And so, what we try to do is take someone from acute management all the way to wherever they need to stop on the spectrum. And we have all of these different loaded strategies along the way.
How do you real time? How do you real time? Like, what criteria, measurements, or markers are you utilizing in clinic to real time let you know a patient has transitioned out of one level to the next, to the next, to the next? In your 6 degrees of Kevin Bacon or your 6 stages of rehab to fitness categorization, like what are you using to let you know the patient is ready for the next category, the next category, the next?
So, some simple rules I use what I call an 80% rule. Like, if you can show me you're 80% on your way to whatever the end stage of that category is, we're going to start introducing stuff from the next stage. So, that's just a simple rule that I use. One of the things that we try to do with our elite athletes is we'll start everyone off on some form of either HRV or simple subjective strategies. Like I'm very much, we use a CNS finger tap test on the smartphone device. And we use that as a metric to measure baseline of homeostasis. And that way we can see how the interventions that we're doing to them change their biology as we're doing it to see where their readiness.
Hey, Tom, what is the tap test? I'm familiar with other metrics like HRV, but I'm not familiar with what the tap test is that you kind of described and what's the utilization.
So I'm not an expert in the tap test, but how we use it and what I remember from the literature, I think it was originally designed as a test to look for deficiency in fine motor skill. And I can't remember the population they were using it in, but what they found was that it was a really good measure of central nervous system fatigue, and they started applying it to athletics. And so it's a fine motor skill, and all you do is you take your smartphone, lay it on the face down or face up, excuse me, and you start the app and you start tapping on the phone as fast as you can for 10 seconds. It records the number. You do that 3 times, and that gives you
Okay.
your baseline. And then how we yeah, you just tap, right? Essentially, how we use it is when we start a new patient, or particularly in high level athletics, when we start a new athlete, we have them get their baseline. And then every day, when we have them record it, so we can see if the interventions that we're doing, how they're changing their biology, and if we're doing too much load or if we need to actually add more load. You could use things like HRV, which is the gold standard, but HRV can be relatively expensive and cost prohibitive for some people. And so we like the tap test because it's $1. Everyone can buy it, and it gives you a good chunk of the same information. Like I was saying, for foundational kinematics, we're just looking at normal joint ranges of motion. So you could use things like goniometry to determine if someone has their 70 degrees of hip flexion or whatever we determine is the baseline standard. For motor control, we're really getting into like force dynamometers and just measuring force outputs to see if they're relatively normal for the population. But then that also dictates that if you're working with groups or teams like I do, we want to take these measurements beforehand so we know where they are in percentage of their baseline. So that's another conversation that could be had of why it's important when you're working with groups to take all these measures at the beginning of the season so you know what to compare it to when they get hurt. Functional integration, or I'm sorry, for motor control, one of the other things we do is we also use the Y balance test. I think it's an easy and simple assessment of dynamic motor control. And so, for instance, if we're talking about a lower extremity injury and someone has a 72 centimeter anterior reach at the beginning of their baseline, and we're at 60, we know that we've got some more work to do to get them back to normal. It's a very cost effective. I think the Y balance test kit is $250, I think, something like that. And it gives you a lot of really great information for very little time. For functional integration, we use the functional movement system. So we want your FMS score to be over 14. And then we also use global strength testing. So whereas when we do isolated dynamometry and motor control, like can your quadriceps in a isolated position, can your quadriceps produce X amount of force? When we do functional integration or GPP, we're going to say, how much can you squat? And how much did you squat before? So if you squatted 200 before and you're at 120 now, obviously we know we've got some work to do.
Tom, is it a max lift or you do a 3 to 5 rep max? Like, what's that criteria?
For injured athletes, I like 5 to 10, honestly. But I've worked in the past, worked with a ton of maximal strength athletes. So as we're progressing towards the end, I was like, we got to see where you're at, right? For normal athletes, I like the number 5 because it's not quite maximal, it's not quite submaximal, so it's heavy enough but not light enough to where you're doing it for more than 10 reps. And then there's many charts where you can compare that to what we could see as normative standards for the age, sex, and sport. For power testing, we usually like to use either like velocity based testing or even
Force
things
plate?
like, let's say, well, so I don't have a force plate, but I'm working on something for our course where, I mean, you could use like VBR testers, velocity based testers. One of the things that we did in one of the colleges I worked at is they had a velocity based unit called Rep One. There's 100 of them out there, but we would do a vertical jump test every week with the Rep One device, and we would measure their velocity. So we measured at the beginning of the season, we knew what their baseline was, and we would use that as either part of our rehab protocol or even as a week-to-week measure of readiness. If we saw a percentage of change in their velocity jump, we know we were either doing too much load or they weren't recovering enough. And so we like velocity-based testing. You can use force plates. I'm trying to think of what my other colleagues are using for kinematics. Kinetics, sorry. Force plates are great. They're just relatively expensive. But I also think you can get the same information out of just a jump mat. It's not going to be as precise and give you like velocities, but it'll tell you jump times. And if you're just trying to have a simple measure for cost effectiveness, I think a jump mat would work relatively well. But if you're going to
Yeah,
spend the money, you might as well get some type of velocity based tester. The Rep One unit's like $225, and it'll actually
you're
tell you
harkening back.
velocities, meters per second, etc.
Yeah, you're harkening back to my exercise physiology and my bachelor's and master's degree, where we used to do things like the wind power test. We're on a bicycle pedaling as fast as we can, or rate of force production. We'd have a flight of stairs, and we'd have to run the flight of stairs and see how fast we can get to the top as a marker of like maximal performance, broad jump, vertical jump, stuff like that. Let me bring it back to one topic that you mentioned that's probably more in the space that most people in our fields, chiropractors and physical therapists, see folks, is the central nervous system fatigue. For years and years and years, it was, at least in my opinion, undervalued, underrated how much central nervous system fatigue can either A, contribute to injury, or B, is a hindrance. Put your foot on the brake, not the gas, in recovery from an injury. You mentioned the tap test, you mentioned the heart rate variability. Where does sleep play a role in this? Because I've used the criteria in the past of the really simple using your sleep tracker on your watch or on your app, which a lot of folks have. Where does sleep play a role in contribution to recovery from an injury or as a measure of central nervous system fatigue that can help us say you're at risk for another injury?
Well, it's everything. Remember how we started the conversation? Rehab to performance, rehab to fitness is just about human performance, right? We teach a physical hierarchy of needs And there's 25 items on this spectrum, and sleep is number one, right? If we want to be like a human with human life, we need sleep, we need nutrition, and we need sound psychological mindset. Those are the things we need just to be human, right? Sleep is the single biggest factor, in my opinion, for recovery. So if you're not recovering well, if you're not sleeping well, you're going to be in a constant state of overstimulation or sympathetic tone. It's going to, like you said, it's going to cause fatigue to the central nervous system and the peripheral nervous system. And then you're going to be less ready and capable to do the tasks of daily activity or sport. So if you're, one of my biggest pet peeves, and it's kind of in the same vein of what we're talking about, but you have all of these devices, social media, people, salesmen that are talking about all these advanced performance techniques like pneumatic compression, which I love, but ice baths and saunas and cold plunges and all these other things, and they're trying to sell you on the most latest and greatest technology for recovery when most people sleep like shit, and the best thing they could do is just get 8 to 9 hours of sleep. I don't remember the exact statistics, but in our course we talk about you are like 5 to 6 times more likely to sustain an injury if you have less than 6 hours of sleep. Like, why are we
Big risk
not
factor. Yeah,
huge? So why are
it's
we
a
just not?
big risk. 500 to 600% is a huge, huge deal.
Yeah. So, and we have all, and again, don't quote me on like the very specific of it because it's not in the top of my head, and we have all the information in our course. But when you look at that, you go, well, why am I worried about putting someone in a cold plunge? Go take a nap, like go to bed on time. So sleep is the single biggest thing we can do to help with recovery. I agree with you that this idea of central nervous fatigue has been overlooked, dismissed as even part of rehabilitation, because what I like to teach in the course is everything we do is about trying to intervene with the biological organisms. We are homo. So then if we go back to the way that we function, it's all about general adaptation syndrome, right? Biology is about stress and application and response to stress. One of the things we talk about is I think people misconstrue stress, in my opinion. People think that stress is the external thing that happens to your body. It is not. That's called load. So if I punch you in the face, that is a load to the organism, and your body is going to internally respond to that by creating a stress response. And if we apply that enough over time, your body will then adapt to that in a very positive or negative way, just depending on the frequency and the intensity of the stimulus, right? So why are we not
Eustress,
considering this
distress.
in our?
Use being positive stressor, distress being a negative reaction to the
Absolutely.
stressor.
So if our goal, I like to think of myself not as a chiropractor or clinician, but I'm a homeostasis man. It's like, I got to figure out how to get you to point A from point B while maintaining homeostasis and causing long-term adaptation. That's what I do. It really baffles me that we talk about this rehab to performance space, but everyone wants to dismiss how we quantify and use load in order to determine if our outcomes are having the effect on the system that we want. And I get really frustrated in a sense where, let's say you, as an example, let's say you have a chiropractor who has someone who has joint pain, whatever it may be. And instead of, maybe this person's highly sympathetic because of their injury, and instead of maybe using something like a gentler joint mobilization that keeps us under the total systems load, that will give them a stimulus that they need but not over push them into sympathetic tone, they just start smashing joints, which is a very highly stressful thing to the nervous system. Has a positive outcome, but it increases the sympathetic stress. So why are we not thinking about this as part of our process of rehab to fitness? And again, that's one of the things why we decided to create the course, because everything we're doing is about the application of load to biology. And if we don't think about how to quantify that, we don't know if our interventions are doing what we're supposed to.
Tom, let me go. We talked a lot about the macro, the big picture. Let's talk about the micro. Give me a case study that you've had over the course of your career that kind of really clearly and simply illustrates from the day one, visit one, assessing the patient, moving them through this spectrum, and ultimately discharging them. I know you've had these cases over the career. Is there one that kind of really clearly demonstrates this whole spectrum?
I mean, yes, but let me give you just an example case, and we can use like this. I remember a basketball player I was working with at the college I was teaching at, and he had knee pain. I believe it was patellar tendinopathy, if I remember right. And he had been through all sorts of stuff. Nothing seemed to work. And so we did our assessment, and he had virtually no ankle mobility. He had no dorsiflexion. And so they were having him do all sorts of deep squats, basketball, like all this stuff. And essentially, it wasn't that he had a knee problem. He had knee pain because his ankle wasn't moving, right? And so, for acute management, was there something we could do for his pain? In that setting, the best we had was cold laser. So maybe we can laser the patellar tendon in acute management. Now, if you're in your own setting or you have other equipment, you could do things like dry needling. Probably would be pretty helpful to that tendon. You could do probably some taping, like dynamic taping would be great over that tendon. Electrical stim, maybe, but you would probably do that with your dry needling. And then some people have had great luck with shockwave and acoustic wave. So depending on where your interventions are, where you're at, and what you have available, that's what you might use. So maybe we're doing laser for the patellar tendon, and then I'm going to manipulate his ankle and start to mobilize it into dorsiflexion, and then start putting him in motor control into some semi-weight bearing positions that forces dorsiflexion. And then I'm going to have him do isometric contractions into the shortened and the lengthened position so that I know his tissues can control motion at these new ranges of motion we've created. From there, we're going to then continue to, and mind you, all of these have their own progressions, right? So there are progressions within progressions. There's probably 10 different variations of semi-weight bearing dorsiflexion that I use to progress them from maybe something simple in a supine position to where they're half kneeling, right? Then we might start with the same person once he gets into GPP. He's like, okay, you've got relatively the amount of dorsiflexion we're looking for. You've proved to me that you can produce force on either side of the joint to help stabilize it. Now, and then even in that same stage, we probably would do some isometrics for like 5 sets of 45 seconds for that patellar tendon, um, to make sure that we're getting some strength back in the tendon. And then we might put them in functional integration. It was like, okay, we're going to start a progressions of a squat because that's what the inciting activity that you said hurt in the beginning. And one of the things I love about our course is we teach progressions of different exercises. So for instance, with this particular patient, I might start them in a weight bearing assisted squat. So we might do a TRX squat. Then we might progress to a body weight squat. And then we might progress to a landmine squat. And then we would progress to a kettlebell or a goblet squat. And then we would progress to the end goal of doing their back squat, front squat, whatever variation they need to do for performance. As we're doing that, we might also progress them into progressive kinetics, where we're going to start on jumping because that was the thing that really started to aggravate him. And we would start by working on decelerating forces eccentrically, and then we would start eccentric into concentric, and we would have different progressions of jumping based on his particular problem. And then finally, we would work with that to integrate different change of direction drills and agility drills for basketball, and then work them back into a scaled return to practice. So what I love about what we teach and the way I tried to put this together is, I don't know if you've ever seen Inception where they go layers upon layers in the person's dream. Well, we have progressions upon progressions. And so what I'm constantly thinking of is, what's the next thing I need to do to load this person, tissue, joint, or pattern in order to get them to that end goal. So I'm always thinking in terms of what's the
This is the concept of reverse engineering. Know what the end state is, where you want to get the athlete. Start at the beginning, but your plan is with the end in mind, phase by phase by phase.
well, and on that same thing, the name of my business when I practiced here in the States was Engineering Athletes, because that's what I did. I did exactly what you said. What's your goal? I need to be back playing basketball. Okay, cool. Where are you at right now? Or what I would technically say is, okay, you need to play basketball. What does that entail? Let's do a needs analysis. I need to know what you need to be able to do, right? And so we would write those things down. I need to be able to jump. I need to be able to sprint this far, et cetera, et cetera. It's like, okay, I know what you want to do, back to basketball. I know what you need to do, X. Where are you at now? That's where our assessment comes in. Well, you have knee pain and you have 5 degrees of ankle dorsiflexion. Okay, well, now we've got to create a plan from this point here all the way over to that point there, and we're reverse engineering the process. So I always start with the end in mind and work backwards, because that's the only way you can do it effectively.
It's a
But you can't do it effectively
good place to
unless
be.
you understand where.
Let me sidetrack here, sidebar a little bit. Exercise selection. It's kind of an interesting topic. I'm going to put the words quotation, use my air quotes here. How do we know, or how do we assess, or how do we develop what are good exercises for patients? And to me, at least, a good exercise is an exercise that's appropriately matched for the age, sex, and demographic, that stimulates and challenges a patient effectively towards the adaptation they need or the goal that they've created and you've kind of agreed to for their process. So, how do we go about determining what is a good exercise for a patient?
Well, I believe in general, there's no bad exercises, just the wrong exercise for the wrong person, right? There are some exercises that I just don't like, and I could give reasons why. But in essence, what I
What's
always
high
look
on
at
that
is what's
list?
the
What's high on that list?
kipping pull-ups. Kipping pull-ups, they're stupid. When you think about the kinematics of a kipping pull-up, most people don't have 180 degrees of shoulder flexion and end range thoracic extension. And so what's going to happen when you drive rotational inertia into that joint? Well, it's going to put you in an end range position that you can't control, and all that stress is going to go on the passive tissues. If you've demonstrated to me that you have 180 degree plus of shoulder flexion and end range thoracic extension, and then you want to do that, that's a choice. I don't like it, but you've earned the right to try to attempt that exercise. When I think of generally prescribing exercises, the first thing I ask is, what's the goal? What are you trying to accomplish? And maybe it's, if we're going back to my knee patient, it's maybe I want my my knee to stop hurting, and I need to generally strengthen my quadriceps so I can play basketball better. I'm like, okay, so if the goal is decrease pain, increase force output, then the next question I'm going to ask is there a specific joint or tissue or pattern that I need to load? Which of it? So in that case, it might be first I need to load a tissue, patella tendon, then I need to load a pattern, the squat, right? And then I go, okay, if I choose an exercise to meet that therapeutic goal, which I need to look at the risk benefit of that exercise. And if the risk is relatively high, I go, is there another exercise I can choose that has half the risk? And if the answer is yes, I choose that. If the answer is
Yeah,
no,
I think
then
about
I
this.
go, okay, I have to use this. What's that?
I think about this like you mentioned a second ago as a matrix, low risk, high reward. That's the ideal starting spot. If it's high risk, low reward, why are we doing it? Kipping pull up, muscle up would be
We need to pick
another
a different.
one. Yeah, exactly. So the matrix, low risk, high reward. Then you've got high risk, low reward. Then you've got high risk, high reward. With Dell, you can get into that category. It just has to be a finite amount of that load, high risk, high reward, because there is a benefit. We just can't do it a ton, or else we overexpose you to the stimulus, which may trigger your injury.
Well, what I always think about too in the same vein is what I like to talk about is micro progressions, right? I'm not trying to annihilate you. I'm trying to give you the lowest dose that you need to cause the adaptation that we're looking for. And then over time, we can increase the load because you become more tolerant to it. But if you're already injured or in a state of sympathetic stress, why would I want to come with the thunder knowing that's either going to further damage the tissue or then cause you overstimulation and you're not going to be able to adapt to it? So it doesn't make sense. That's why we always talk about what's the therapeutic goal, what's the risk reward of choosing that exercise, and then are we using the lowest systems load? And then finally, when I choose an exercise based on those criteria, the last thing I always look at is execution. Like how do you execute this exercise? And it has to be with integrity. And when we teach integrity, we teach the ABCs. Integrity is alignment, breathing, and control. Meaning, if I'm going to choose this exercise for you, can you align the joints properly? Meaning, for instance, maybe if you're going to squat, can you get the diaphragm over the pelvis, which is an optimal joint position? So can you align the joints? Can you hold that position? then can you breathe to create intra-abdominal pressure and or use that pressure to create spinal stability, or use that in conjunction with some form of bracing based on the task? And so that's breathing. And then the last one is control. If you can maintain alignment and breathing, and that gives you stability, then can you control the execution of the motor pattern from the starting position to the ending position? And if you can't execute an exercise with integrity, we have to regress you backwards to some place where you can. So, for instance, let's say we're doing a goblet squat, and that's the exercise we chose for whatever particular reason, and the person can't maintain alignment, breathing, and control. We have to regress them back to a landmine squat, because the landmine is going to give you some artificial stability with an external load in the pattern. If you can't maintain integrity during a landmine squat, maybe I'm going to regress you back to a bodyweight squat. That's where you've shown me you can maintain integrity. So right now, this is the right landing spot for you for the exercise that we've chosen. So you have to think of all those criteria. And one of the things that I like to talk about in our class is, like, everyone thinks in the fitness industry that the exercise prescription is really simple, and it is. But you go, we're just going to pick an exercise. I was like, well, how do you know that's the right one for Dino? How do we know? Did we assess him? Do we know where his tolerances are? Do we know that that meets his therapeutic goal? What's the risk of that exercise? Are we using the lowest load? Can he even do it with integrity? And if the answer is no to any of those things, we got to rethink the way we're prescribing our exercise. But I feel the same way about prescribing interventions too. So hopefully that
For
answers.
years and years and years, I think rehabilitation's been protocolized, and it's easy to process a high number of people through a protocolized system, and it's easy to push that down the chain. But there's inherent danger in that, an inherent problem. The inherent problem is you could be prescribing the wrong force, the wrong load, the wrong exercise selection for that patient at that point in time, and accidentally sabotage the recovery of the patient or the end game, their end goals.
Well, and we see that a lot. I think that's why a lot of times either return to play slow, or people get injured again as they're coming back from an injury. If I've seen a case recently where I'm at, where a physio was had a knee patient. I think it was something like patellar tendinopathy. Their first exercise back was a loaded front squat, and I'm like, how did you choose that? But B, I don't know, did you even try like isometric contractions first, or did you just jump right to? So if we're talking a spectrum, like supine isometric contraction would be here, and over here is their front squat with a barbell. Like, you chose the second hardest version possible to start with. It's like, how about we start over here and do these little baby progressions along the way? And that way we know that there's time for those tissues to adapt positively, and we're not forcing them into further stress.
Yeah, one thing it was interesting is I started as an athletic trainer, student trainer in the 90s, and here we are in 2024, and it was all about fast progressions, get people back faster and faster and faster, and creating hacks, whether it's therapeutic modalities or these accelerated ACL protocols. And sometimes biology is slow. Sometimes the biological tissue does not respond. You may get a quick, rapid adjustment of the central nervous system, peripheral nervous system. Nerves can be easily fooled, but biological tissue loading is inherent. Load it, unload it, reload it, unload it. It's a constant game that you have to play, and somewhere in that, it got lost. It's interesting you bring that up. That again, it's a constant up and down and struggle with micro progressions in that field. Have you seen that too, where there's a too much of an emphasis on the return too soon and pushback by the body in some of these cases?
Absolutely. I mean, I think that's why people like you and I have jobs, is because people start to, you can't fool biology. You can hack parts of biology, like you said. Can we do things to trick the body and the nervous system into giving us what we want temporarily, in order to move joints, tissues, and load them in a way that we can progress to long-term adaptation? Yes. But the body takes the time the biology needs to heal and adapt. We can't change that. Why do a lot of these injuries continue to occur? Because you're trying to speed up a process that takes a specific amount of time. Rather than using the approach that we're teaching, is say, look, when I come up with a plan, I go, how long does it take this tissue to heal typically? 3 months? Cool. Then I have 3 months to get you through all of these stages of care with micro progressions along the way to make sure we're meeting the milestones. Because in my mind, my success rate is not how fast I get people back to sport, but how many people don't get re-injured. That's more
Yeah,
important.
yeah. And if you talk about cumulative, like the cumulative loss of that patient to sport, like, all right, 2 weeks with an ankle sprain, but 4 weeks later they're back, or they're missing time, missing performance, or, if you have an adult, like a mom that has to care for their child and they can't pick up their kid, and, it's a big deal. And all of a sudden, like, they feel better, but they're re-exposed to the stimulus. You didn't go over how to pick up the kid from the floor, deadlift progression for crying out loud, or hip hinging or something, and it bothers them later. What cost does that have? That's the untold cost sometimes of trying to advance or progress somebody too quickly when they're not ready. I saw a really good thing on your Instagram page about you had this really nice chart of complex, or a quote, complex versus simplicity in building adaptations. And it was like 4 or 5 pictures, and the language really struck me. Can you explain a little bit about complex exercises versus simple exercises and developing that adaptation? Because I think we try to get a little too cute sometimes with exercises the patient's not ready for.
Yeah, exercise should pick the simplest. There's a bunch of old adages, and it's escaping my mind, but it's like sometimes the simplest solution is the best one. And even if we talk about exercise selection, in fitness, particularly in order to stay relevant on social media, people are always talking about vary your exercises, muscle confusion, your body doesn't, wants always something different. Then why is it the people who I make the most progress with are the ones we consistently use the same exercises over and over and over and over again? All I do is find different ways to manipulate the variables of the same exercise to change the way that their body's perceiving the stimulus, right? I don't do cute, trendy. I like simple stuff. There are some times where you see a trendy exercise and you're like, wow, that's a really novel way to do this thing that I've not tried before. Let's try that. But that's not usually the norm of the exercise I choose. That's the exception. I think I go back to when I teach and what we talk about in our course. It's like, I really think if we as chiropractors want to be seen as leaders in this rehab to performance idea, we really have to understand load is king to biology. The only reason why we're doing all these cute and trendy things in the clinic are to get their nervous systems and their bodies into physical positions where we can actually start to accumulate load and make long-term physiological change. And maybe in your environment, if you're in a multidisciplinary environment, maybe your job is just the person who manipulates the ankle to get the ankle moving so that the PT can put it under isometric load so the strength coach can put it in a squat. That's cool. But you have to
Yeah, yeah.
understand the entire process in order to know where you fit in with the skills you have. And I just like to do most of it myself. I work in a ton of integrated environments, but you can't work with other people if you don't understand the model and your role within the system.
Yeah, that's the old Bill Belichick adage, do your job, right? And if you do your job, and then you're setting the next person up for success, which sets the next person up for success if you work in a multidisciplinary model. Hey, I'm going to manipulate the crap out of the ankle so I get that dorsiflexion, so I can give the physical therapist the opportunity to introduce more tolerable load for the patient for the adaptation. So I give the strength coach the ability to now, build a beast or maintain physical capabilities in that high level athlete.
Yeah, it just kind of played into the system that we're teaching is it's all about load. I'm applying a physical load in manipulation, but it's a low systems load for the therapeutic goal of getting the ankle to move. So I can pass you off to the physio who he can use your internal external contraction to create force outputs in a low threshold environment to stabilize the joint so that I can put you in a squat so you can actually perform a loaded squat so that you can jump during basketball. But you have to understand.
We've talked to and kind of danced around this topic here a little bit, and I just want to dive a little bit further down the rabbit hole. You had an interesting little graphic. I remember looking through some of your social channels on the stress versus adaptation curve. What is this? What is this concept of stress versus adaptation? What does that mean, and how do we implement it, or how do we understand it to better help our patients and clients out?
I think it's everything. I think it is the single most important thing that I do, that you and I and people like us do, is we have to understand stress. And like I mentioned earlier, when something happens to your body, that is an external load, right? It's something that happens to you. It's a burden to your system. Your body responds to that in the form of an internal stress. As it's responding to that stress, it has to find a way to accommodate to bring you back to homeostasis in an acute environment. And then you're back to normal. And then if you continue to perceive that stress, you will go into further resistance and then long-term adaptation. The goal is to be able to adapt every repeated time that you see a similar stress. That's the general adaptation syndrome. And so we need to understand that we need to be really good at applying and quantifying the loads we're applying to our patients in order to get them to the point where they can adapt for long-term physiological adaptation. I think it's everything that we do. And I think the goal is over time, with you look at the stress or load adaptation curve, is to be able to shift the curve from someone from here, if this is their starting point, to the right, which means that we can apply more stress before we see changes in negative adaptations, right? The goal is to shift the curve. Because if I have an athlete who can only tolerate 100 newtons of force in the knee, and I build their knee range of motion and capacity for tolerance at that joint to 500, I've just created, 5 times the tolerance. And so, do you think that person's going to have more force output, more ability to improve kinetics and better performance? Absolutely. They're going to be more tolerant to stress, more resilient to force, which means they're probably not going to be injured as much. So everything we're doing is about long-term adaptation, building resilient, applying load to build resilience to stress, to make our athletes adaptable to multiple environments.
Yeah, we're basically using this concept of progressive application of force and then backing off and then kind of like a maestro conducting the orchestra to bulletproof them.
100%. 100%.
Is the tool of choice always strength training, or how do you mix and match what tool is appropriate to better bulletproof that client, that athlete, or that individual?
I think it just depends on the context of the person, their individual specific deficiencies, and the needs they need for their activity. Like, it's really hard to blanket statement, how would you do X? Like, I need specific details. If you want a general statement, start small, think big, meaning start with the lowest systems load. And if it's not enough, keep working up till you find the place where it is. And then you just keep adding a little bit at a time. That's the term of micro progressions. If you look at a stair step, do you want to have to jump over 3 steps, or walk over 3 steps at a time, or do you want to take these little steps along the way, because that's going to be a hell of a lot more efficient and a lot more appropriate than taking these massive jumps.
Yeah, I think you hit the nail on the head earlier when you started to hammer the point of a needs analysis. And that was kind of a general statement, but to your point, the specific answer is what does the client or what does the patient need? Hey, Tom, what are your top three? We're going to go quick and dirty. What are your top three recommendations for topic of injury prevention? What are you giving most patients or most clients?
So, what I always talk about is you want to be as resilient to stress. To prevent injury, you want to be resilient to stress. The best ways you can be resilient to stress is to have a larger physiological buffer zone. So, first thing is efficient movement. Can your joints get into the right positions to absorb forces and adapt to the stresses of training? So, can your joints move correctly? Then it's about fitness capacity, meaning, do you have the physiological requisites to produce force outputs for a long period of time? And if you don't, we need to obtain those. And then finally, if you move well and you're fit for your activity, then it's about homeostasis and load management. So, can we quantify forces and help create recovery strategies to help you maintain homeostasis as we're loading and working on tissues? So, for injury prevention, it's all about movement, fitness, and load management.
Top three for maximal performance. It's not just about getting back to the activity, it's about whatever your God given ability and maximal ceilings are. How do we get to the maximal performance?
Performance is about readiness and readiness and preparedness. So for readiness, it's all about recovery. That's essentially what we're talking about. So for recovery, it's about sleep, nutrition, and psychological mindset. And then there's other things we can do, supplementation, hydration, etc. For the preparedness side, then we just go back to talking about fitness. Do you have the physiological requisites to perform your sport? And that's based on training. And so for me, if you want to perform at your peak, make sure you sleep, make sure you eat well, and make sure you got your mind right.
Optimal recovery. Give me your top three. Quick and dirty, optimal recovery.
Sleep, nutrition, and I would say hydration and supplementation.
And this is generally, we talked about the athlete. Let's talk about the average person or every person. Give me your top three recommendations to live a long, healthy, productive, and physically active life.
I think it's super simple stuff. Eat well, move a lot, and move well. And then I think the last piece is have really good social relationships. Find things that you enjoy with people you enjoy and have a great time with life.
Yeah, 100%. On that note, we as humans are social creatures. We need good social interactions to motivate us, to power us, to replenish our batteries. And sometimes we forget and underestimate the importance of the social environment to living a long, healthy, and productive life. And I have an elderly parent, and I'm seeing the effects of sometimes social isolations on the mood, the psyche, and then the physicality. Recap and closing thoughts. What do you want our listeners to know? We've been going over an hour. What do you want our listeners to know about your methodology, your system, you, and what do you want our listeners to take home?
I think the big thing is as clinicians, we really just need to think about the entire spectrum of loading strategies from rehab into fitness and how that affects performance. I think for me personally, we created our rehab to fitness course for this very reason. We have two versions. We have a 16-week cohort model, but our new course that we're just launching is 125 hours. So it's a lot of detailed information, and we've called it the Clinical Human Performance Practitioner Certification because it goes through everything we just talked about, because rehab is just about human performance. We have our module now where essentially you can take it at your own pace, kind of like you would the CCSP. So you have to get through all the coursework in a year, and then you can come to our live class where we work on all of these things hands-on, and then you can become certified in clinical human performance. I guess the big other thing would be, and we would love to see you all take a class. I think it's some information that most chiropractors and even physios don't get. And it's stuff we need to know if we're going to be working in these high threshold and high-paced environments. And then if for me, if you want to find me personally, I'm an open book. I love to talk about this subject and answer questions. So you can reach out to me on Facebook. It's Tom Teter, or my professional page is Dr. Teter Jr., or you can reach us at Rehab to Fitness on social media, whether it's Instagram or Facebook. Send me a message if you have any questions. I am happy to talk about this. And again, I would love to see our profession start to move this direction towards human performance so that we can help more people and keep athletes performing at their peak.
Yeah, I appreciate your time. I appreciate your talents. I will post for our listeners all those links that you mentioned in the show notes. I highly encourage our listeners to kind of delve into this category, not only on behalf of their clinical practices, but good sleep, good nutrition, good hydration is a universal message that we should be taking the charge of as chiropractors, because for too long there's been this disconnect between the medical profession, the rehab professions, and then just good, active, healthy lifestyle choices. And I think Doc did a great job of summarizing. This isn't, we live in islands and silos. This is a spectrum. So, Doc, thank you for your time. Thank you for your talents. Thank you for sharing this information.
I appreciate you having me on. Thanks a lot.
Thanks a lot. We are the We Fix Pain podcast. This is episode number 26 of Dr. Tom Teter, and we are signing off.